Well, thank you for joining yet another webinar from the Prostate Cancer Foundation of Australia. My name is Katie Clift, very pleased to be moderating today on what is a very special webinar focused on the publication of new draft 2025 clinical practice guidelines for the early detection of prostate cancer. And I'm pleased to share that these guidelines are now open for public comment. This is following 2 years of very exhaustive work led by PCFA in very close collaboration with experts and consumers from around the country. And to discuss these guidelines, the fact that they're open for submission, the development in detail, I'm very pleased today to introduce an esteemed panel. Professor Jeff Dunn AO, the Head of Research and Chief of Mission at Prostate Cancer Foundation of Australia. Jeff is ranked by Stanford University as among the top 2% of scientists worldwide for oncology and clinical medicine. We have Associate Professor David Smith, the Interim Deputy Director and Prostate Cancer Stream Lead at the Daffodil Centre in Australia. He's been involved with the development of the new guidelines. And Adjunct Professor Peter Heathcote, a urologic surgeon with a special interest in cancer of the prostate, robotic surgery, and pelvic oncology with over 30 years of practice experience. So as I said at the top, a very esteemed panel. And to open our conversation, Jeff, I might turn to you first, because I think it's important for us to contextualize what we're talking about today, and to focus on a bit of the history. So in 2016, we had PCFA and Cancer Council Australia release the first national evidence-based clinical practice guidelines for PSA testing and the early management of test-detected prostate cancer. They expired in 2021. Since 2023, PCFA has been undertaking this review. Tell us about this process and I guess some of the history.
Yeah, look, thanks, Katie. And as you said at the outset, it's terrific to have this webinar on such an important occasion, because while there's still work to be done, the public consultation period for these new guidelines is a milestone, and one we're delighted to see come around. I mean, you're correct. The first clinical practice guidelines were put out in 2016, and a lot has changed since 2016. There have been significant developments in medical technologies. There have been significant developments in clinical pathways, how our clinicians manage the disease. There have certainly been great advances in particular imaging technologies like multiparametric MRI, which have changed the landscape. And I think importantly too, there have been shifts and developments in community attitudes, community understanding of prostate cancer and expectations about what we can do about the disease. I mean, let's be clear, prostate cancer is now the most commonly diagnosed cancer in the country. And, 4,000 men die each year from this disease. We estimate that since the 2016 guidelines were published, about 30,000 men have died from prostate cancer. We need to do something about that. So we've pulled together, after much work, involving, as you said, leading scientists, clinicians, consumers from around the country, to help us develop a new set, a revised set of guidelines for the early detection of prostate cancer, which are based on the latest evidence, which are based on the best expert advice, and which are also based on consumer sentiment, consumer feedback, what is important to them and those people in the community. We've put it out for consultation, and we're hoping we get a strong response to learn how we can actually do even better before we submit to the NH and MRC for their approval.
And you mentioned 2016, a lot has changed. I mean, we're talking about developments in standards of care. You referenced new evidence, technologies. What are some of the main highlights or I guess milestones in that sense that you've seen change since 2016 that have informed this new draft?
For sure. When we get to Peter a little bit later on, he can develop this a little. But certainly, since 2016, there have been giant strides made in imaging. I mentioned MRI, multiparametric MRI. There have been significant developments in the way our clinicians manage the disease. When the 2016 guidelines came out, around 65% of men with early stage prostate cancer were put on active surveillance. Now it's about 80%. So there's been a significant jump in the numbers of men being treated with active surveillance as opposed to there was back then. These sorts of things in a combined fashion deliver us to a point where these new guidelines are based on a different set of facts, a different framework. And there's more evidence all the time emerging, maturing, evolving. So what's critical for us, once these guidelines are approved and launched, is that we build in implementation strategies and priorities, one of which must be ongoing monitoring and review to update as new evidence comes to light.
Absolutely. And now people might have heard about the draft of these guidelines on the website, through some of the news and media stories, social media. If you were to kind of, and I know it might be a big task, it is a big milestone, a lot has changed. If you were to sort of say these are some of the top headlines that people should be aware of or take away with these draft guidelines, how would you summarize that?
Okay, so in terms of shifts since 2016, what's new? For the first time now, there's a recommendation that for men interested in their prostate health, they should seek a baseline PSA from age 40. That's up to them. There is a strong recommendation now for men aged 50 to 69 for their general practitioners to offer those men a PSA test. There's been some change in the recommendations about men over 70 or men 70 and over, whereas in the previous guidelines or the existing guidelines, PSA testing is not encouraged. That's been changed now to, base that decision on clinical assessment of those individuals. There are stronger recommendations about men at higher risk of prostate cancer. That's men with a family history, a brother, a father, an uncle with prostate cancer, men from sub-Saharan African descent who are at a greater risk, and also men with a family history of the BRCA gene, which is often associated with breast cancer, but with a family history of BRCA gene. Those men, we now recommend strongly seek appointment with their general practitioner and commence testing from age 40. And for the first time, there's actual specific reference to Aboriginal and Torres Strait Islander men. However, concerns about outcomes persist. As a priority population, we recommend earlier testing from age 40. So these are some of the major shifts. In a sense, we see the 2025 guidelines move from one of PSA testing, which was the focus of the 16 guidelines, into a more broadly based, proactive, evidence-based framework for the early detection of prostate cancer, where risk assessment and harm minimization are priorities.
Absolutely. That is a wonderful summary. David, let's turn to you right now because Jeff has given us a great opener there and context to these guidelines. In terms of the need for this review, I mean, the burden of prostate cancer in Australia is obviously extremely significant. It's the most commonly diagnosed cancer in the country. From your view, how urgent was the need for this undertaking of this review?
Yeah, look, it was essential that we reviewed the guidelines again. And as Jeff has pointed out, we've got it's our most common cancer. And it's our second most common cause of cancer death. 1 in 5 men might be expected to be diagnosed in their lifetime up to age 85, and we've got some of the highest rates of prostate cancer incidence in the world. Partly that's because we've already been quite good at testing, but we've been disorganized in our testing approach. And so the review of the guidelines and where we're at right now is really helping to organize our approach to testing and synthesize all that evidence that's been there for the last 10 years into a set of documentation to guide and provide communications to those most at need, both the clinicians and men themselves who are embarking upon the pathway towards thinking about prostate cancer testing. So I guess also one of the issues that we realize this is a really important point. Again, 4,000 men approximately die every year, and we at the Daffodil Centre have estimated that about 25,000 premature deaths from prostate cancer will occur between now and 2044. So that's when we talk about premature deaths, that's deaths before the age of 75. So there really is a strong need to have a better approach to what we do in relation to the early detection of prostate cancer. And again, reiterating all the issues and efforts and technology and clinical practice changes that have occurred in the last 10 years. It's vital that we, as a leader, as Australia is seen as a leader in this area, that we have a coherent, locally tailored and current set of guidelines upon which we can base the best practice evidence.
And I guess that's one of the main takeaways, certainly from a broader perspective, to see that Australia is leading the way. This is a world first approach in many ways, isn't it?
Look, it is. And I think also harking back to the 2016 guidelines, we're sort of standing on the shoulders of giants who put those together. It's an incredible piece of work from 2016, and calling out Professors Bruce Armstrong and Professors Willis Marshall, who really led those guidelines. They pulled together the stakeholders who were interested at that stage. They put an incredible amount of work into the guidelines, and so too do some of the people who've been working on the technical review this time around, and particularly also speaking about Susie Hughes, who's been at the heart of all the technical reviews that we've done that have provided the evidence together. So we were, as I say, standing on the shoulders of giants that put together the 2016 guidelines, and I think we're sort of leading the world internationally in this area because we've got a high proportion of men who are treated with active surveillance, who've got low risk disease. We've got MP MRI built into our public health systems now as well, and biopsy approaches have changed as well. So I think we'll pull out a few more of those as we go through this discussion. But all these things place us at the centre of providing a gold standard in terms of what we should be doing in relation to the early detection of prostate cancer.
And you've been part of this working group that's informed the development of these guidelines. We talked about paradigm shifts, for example, transitioning from this opportunistic testing to an organized testing program. What are some of the takeaways that you have experienced from this whole undertaking, I guess, and development?
So what I've seen over the last 20 years I've been working in prostate cancer is quite a big shift away from what we used to say was it's a very controversial area. Well, I think what we've shown in the last year or so in terms of putting these guidelines together is that we've got a lot more agreement in terms of what we're doing. So I'd like to think that a lot of that controversy has been dealt with because of the technology shift and the changes in clinical practice, and so I think that's been one of the major paradigms that's been really encouraging. But of course, the technology, often the technology is out there and is being used before the guidelines can catch up, and I think now we're at the point where the guidelines have kind of caught up with the technology, and we're in the right place to be able to put out these guidelines to be much more proactive and provide some clearer statements about what should be done. Harking back to 2016, I think that was the issue where there was still some, what should we do? Weigh up the harms and the benefits in relation to prostate cancer testing. And now I think we're far more certain about saying, here are the benefits, and there are some potential harms that you should know about, and decision support should allow men to get to the right area in that. But it's the balance of those is really shifting towards a more proactive approach where we offer men the opportunity for early detection of prostate cancer, rather than sitting on the fence and providing them with some information and letting them go away and scratch their head saying, I don't really know. What do you think you should do, doc? So I think that's where we're at now, and that's where a lot of the paradigm shift has really happened.
I think that's a really important point, especially on clarity for men and making it, as clear as possible for them to make those informed decisions. Turning to you, Peter, because you're the chair of the expert advisory panel that's developed the guidelines. We've heard from Jeff and from David their experience. What has your role entailed? What have you taken away from the process so far?
Oh, it's been a fascinating, stimulating 2 years. It's been two of the most professionally rewarding years of my life, to be honest. See, in my years as a practicing urologist, I've seen us move into a paradigm shift and a real confidence in offering early diagnosis and unlinking diagnosis and treatment. They're quite different. Previously, a diagnosis meant you went down a treatment path, and that's just not the case now. And both David and Jeff have mentioned active surveillance. Australia is at the forefront of active surveillance in the world. But, you know, on the subject of Australia and being at the forefront, we are so blessed to have access to MP-MRI in this country. And as both David and Jeff have said, that's been a game changer. You know, we estimate that about 50% of men with a raised PSA, once they've had an MRI within our guideline structure, they won't need anything more invasive. They can be reassured and sent home. And that's to do with harm minimisation. That's the first part of the harm minimisation. Of course, we have changed in Australia to largely transperineal prostate biopsies. And then again, that's harm minimisation. It improves the accuracy of the biopsy, but it also decreases the risks of biopsy. So that's the second part. And then the third part is, as I've already mentioned, as the others have mentioned, is this move to active surveillance. You know, 10 years ago, when I said to a patient, look, I think we could do active surveillance, the patient would look at me and they'd see me squirming in my chair thinking, oh, active surveillance probably okay. And so we knew that after 12 months, 50% of men dropped out of active surveillance. But we now know in 2025, we're confident with MRI, with PET scanning, perhaps with the biopsies, that we can leave these men on active surveillance long term without harm. And so we're confident, our patients are confident, and they stay on surveillance and stay out of harm's way.
And this is an important perspective, I think, too. And we'll talk about the consumer, the patient side of things, but this also influences the health experts. And I mean, we've talked about decades of practical experience. How do you expect these guidelines to sort of inform, and I guess what would your message be to health experts and practitioners out there listening?
Yeah. One of the most important lessons we learnt from the 2016 guidelines, and an urgent message from anyone we spoke to, was we needed a set of clear, unambiguous directions. Now, to be fair to the 2016 guidelines, I don't think the literature was mature enough. MRI wasn't readily available. So, as David said, I think we are standing on the shoulders of giants. Make no bones about that. I'm astonished at how good the 2016 guides were, but we've been able to take it to the next level. And, you know, and by moving from an opportunistic, disorganized testing program to this multi-layered harm minimisation program, we're actually improving health equity, because we're going to reach a lot more men in an even fashion throughout the community by giving a clear, succinct message. And when we wrote these guidelines, you'll notice that we've written it in two parts, really. We've written a part for general practitioners with clear, unambiguous sets of recommendations, and then clear, unambiguous recommendations for practicing urologists to follow up. So I can't emphasise enough the health equity part of this. I think we are going to find a much fairer distribution of PSA testing and diagnosis throughout Australia.
I think the equity point is really important. I mean, we heard from Jeff too, how some of the recommendations are sort of split out for different groups. Aboriginal and Torres Strait Islander males, for example. Tell us about some of those inclusions in these draft guidelines.
Well, that's been a major advance, and I'd take my hat off to Jeff for his efforts here, coordinating with NHMRC and providing two major advisory groups that sit over the whole expert advisory panel and help us just get to the right decisions for those particular groups. It's been very helpful. You know, I'm just looking at my numbers here. We've got 54 people in our expert advisory panel, and of those 54, 10 are consumers, about 10 are GPs, and about 6 are urologists and other groups. So it's been interesting gathering those people all together, I must say, and I'd like to thank David and the Daffodil crew for helping here. But what we've done is really, because the literature is so good, the science is so good, we've been able to unify this disparate group giving this simplified, straightforward message. Really important.
Jeff, we've heard about the impacts now on health experts and practitioners, but the patient is really center of these guidelines too. And I know we will have a lot of people watching that maybe are newly diagnosed, they're in that process of overwhelm, they may have family members that are affected. I mean, this is really important to inform, as we've been saying, the proactivity, the clarity on how men and their families make decisions on after diagnosis and through treatment. Tell us about that patient focus and how we're seeing it reflected in this draft.
Yeah, look, yeah, sure, Katie. I mean, it is very important, as you've said. And, one of the things that we'd like to improve upon, notwithstanding the great work of the 16 guidelines, but unfortunately, there was never a public awareness campaign set out about them, and there was never a consumer companion developed at the same time, which was in plain English, which explained the guidelines in terms and phrases and the like, which consumers and community members and families could understand. So a couple of things. First up, Peter's mentioned that the guidelines are in two parts: a primary health or generous practice part, followed by something for after specialist referral. There's a third part as well, which is a whole range of implementation priorities, which we're including as a part of that final report. And these, probably more than anything else, are about making sure these guidelines are well understood in the community, that there is some awareness, some educational activities once they're launched. So we want to make sure that they're well understood. We want to make sure that they're clear. Importantly, and David and Peter have mentioned this, we need to make sure for this 2025 set of guidelines that they are uniformly applied throughout the country, across different health settings, across different states, and across professional groups, because this is not the case in the 2016 guidelines, unfortunately. And what that means is that there's confusion. There is some uncertainty, amongst members of the community and patients. So we need to try and deliver on those things, because when we hear of calls that men and their carers make to our helpline or to our counselling service, or the sorts of things they talk to our prostate cancer specialist nurses around the country about, it reinforces for you the importance of, first of all, getting these guidelines right. And we've done everything we can to do that so far, and it's out for consultation. But then secondly, making sure we leave no stone unturned when it comes to awareness, education, and uniform implementation across the country. So as Peter said, let's make them clear, let's make them workable, and then let's work with all stakeholders: government, community, professional, health agencies, private and public, to ensure implementation and compliance is rock solid and widespread.
And I guess what underpins all of this is that emphasis on early detection. It's in the name of the draft guidelines. I mean, early detection saves lives, right? That's the message that we also need to drive home here.
Well, here, and people out there will know a vision for the Prostate Cancer Foundation of Australia is 0 deaths from prostate cancer. We can only ever hope to achieve that through early detection, improved early detection. I mean, David spoke earlier about, and Peter spoke too, about the quality of our health system, and it is first class. I mean, we'd always like to improve some things, but in a worldwide comparison, we are blessed with our health system. We need to make sure that everyone gets access to it. We need to make sure that we've got early detection guidelines in place. But even with our current systems, there's still far too many men being diagnosed with late-stage prostate cancer. Now, if we could get them earlier, we could improve the numbers even more. We could save more lives, which is what these guidelines are about. Improved early detection, better choices available to clinicians and patients about how to manage and treat that disease, leading to better outcomes and improved survival. That's what we're after, and that's what we're hoping we can achieve through these new guidelines.
Absolutely. And David, people can go online and see this draft in detail. We'll talk about the specifics in terms of it being open for public comment. That's till the 25th of May. But we're seeing recommendations. We've touched on a couple of these in detail, advice for consumers and health professionals, advice about testing strategies, further investigation after PSA test results, early treatment and management and surveillance. What are some of the key takeaways that you'd like to talk through in terms of what these new recommendations specify?
So Katie, one of the ones that we haven't really touched on to this point in time is the issue around digital rectal examination, and the 2016 guidelines recommended that the DRE was not recommended in the primary care setting, but was a method that was more appropriate to be used at the clinician at the specialist urological setting. Now, we have not changed that recommendation. We searched the literature. We found a couple of studies that have been updated in that area, but they didn't add anything to that guideline, and we are sticking with that same recommendation. And this is an important point to make, because when men often think about prostate cancer testing, they think about a DRE, and in some men, there's a reaction, an adverse reaction, and saying, I don't want to be involved with that one. So what we are going to reiterate again in this stage is that the early detection of prostate cancer for most men doesn't involve a DRE, because most men, if they embark upon this, will have a PSA, a simple blood test, and most men will be sent away to say, your PSA is fine, come back and see us in 2 years. And so people shouldn't be afraid of prostate cancer testing because of the mythology that everyone gets a gloved finger inserted up their bum. It's not the way we do it anymore. So that's one of the important points to make as well. I think, and reiterating what Jeff and Peter have said as well, that we've adopted a more of a risk-adapted approach to these guidelines, and specifically for those men who we know are at higher risk. If there's a family history, if there's a BRCA gene, if there's a Black sub-Saharan ancestry as well, we know these are higher risks for prostate cancer, and so those men are encouraged to seek testing at an early age, from age 40. One of the problems with prostate cancer is that we really don't know a lot about risk factors for it. It's not like some of the other cancers where we know sun exposure or tobacco or diet is related to your risk. And so therefore having a set of guidelines that speak to all men, essentially those without symptoms, about what they should be doing is really important. So I think, again, that's one of the paradigm shifts. We've got some more risk-adapted approaches to these issues. And then we've got this harm minimization all through the guidelines, which essentially takes out the issue that used to dog prostate cancer testing, that was spoken of as being over detection, over diagnosis, and over treatment. Now we haven't completely obliterated that, but we've really raised a lot of the issues that used to stand in the way for us to say we'll adopt a more organized testing approach. So those are the really important points that I think that we ask people to provide public consultation on. And this public consultation process is really important, because I'm sure there are things that, while we've been spending the last 2 years getting them right, there are things that could be improved upon, and we really want to hear from the groups who are most affected, and from the general public.
Absolutely.
Itself.
Jeff, maybe tell us a little bit about how people can get involved, what we're in terms of putting forward their thoughts and contributing to the open submission.
Yeah, sure, Katie. Look, we, as David has just said, we are encouraging anyone who has an interest in prostate cancer and these draft guidelines to have their say. So the easiest way for anyone out there is just to go to pcfa.org.au and look for public consultation, and there's a link, all the details there, and it'll walk you through it, and it's an easy process, and we'd love to hear from you. I reiterate, as David said, this is not just for clinicians or medical scientists or hospital administrators. This is actually for everyone, consumers, carers, members of the public, anyone with an interest in prostate cancer and these guidelines really should take the opportunity. And I point out that, the NHMRC, which is our, peak medical scientific body in that regard, and where these guidelines will end up for approval, places very high regard, on the depth and breadth of public consultation. So we are encouraging people, take the opportunity, have your say, let us know what you think.
Absolutely. And these draft guidelines are open for public consultation until the 25th of May. So you can go, as Jeff said, to pcfa.org.au. Peter, let's talk a little bit more in detail about, fundamentally what needs to change with health experts and practitioners, but also on the consumer level, in terms of really seeing some of these guideline recommendations come to life and be implemented most effectively in Australia.
Well, thanks, Katie. I'll take a step back for a minute. A lot of my colleagues have said to me, why is this process taking 2 years? Well, I'll tell you why. Because we're doing it under the NHMRC guidelines, and that I can't emphasize that enough. The amount of work that's really good science that's gone into the background of this is important. But by complying with NHMRC and getting NHMRC approval, we can then influence the next 5-10 years of government policy and really get the implementation right. As I've already said, avoid this health inequity issues. We've also got all of the major medical colleges in Australia. We've had them on the steering committee. Well, and hopefully I'll be very disappointed if not, but we should have endorsement from all of the major colleges around Australia. And again, that's an important unity. We're in furious agreement about this, and let's continue that way. But that's the key, isn't it? We've been through a very strict, scientifically based process, and with NHMRC approval, we'll be able to influence government and hopefully go on to the next stage of promulgation, education, and health equity access.
And I guess that point on monitoring and evaluation and making sure that these draft guidelines will be implemented, what are your thoughts there? It's picking up on the points that Jeff and David have already made.
We hope to set up with PCFA and federal grant money an ongoing review team, which will look at any advances in the literature. We don't want another 10 years before the next review. It's got to be ongoing all of the time. And so, for example, it may be that in 6 or 12 months, the literature on biparametric MRI matures, and we can recommend moving to a cheaper and a quicker modality of MRI triage without losing the accuracy. And that's just one example, but there'll be a lot of those examples, and we'll be monitoring uptake of PSA. Why is it that more PSA tests are done in the southeast corner of Queensland and not up in the north? Those sort of issues.
I think this is great in terms of looking to the future and how these will be implemented. Jeff, tell us about what's next. What happens after this open submission closes? What are the sort of next steps that we will see in the short to medium term future?
Sure, thanks, Katie. So first up, we will be, we've got a template, we've got a process in place to receive feedback, to analyse, to report on it, and then to respond to it. And so those processes are in play. What we need to do is allow the 6 weeks, then we've allowed ourselves another month to revise guidelines as needed on the basis of that feedback. We submit then to the NHMRC in June in preparation for their council meeting in early August, where this is on the agenda. We will be hoping for approval from them as soon as possible, but we will need to work with them on that as the time arrives. Can I point out, and Peter alluded to this, approval of the guidelines when we get them there, that is going to be a magnificent milestone, but it is just the first step. And if you think about what's next, we've spoken about implementation priorities. Peter just mentioned one there about monitoring and evaluation and surveillance, over time. We've spoken about a consumer companion. We've spoken about public education and awareness campaign. But there are a range of other things, about future research, about higher priorities, all of these things in there. There's a whole process to occur once we get them approved. These are there, they're in play. It's been important for us to keep a track of these along the way and make sure that we alert and keep, the government, the health system and other agencies appraised of what these priorities might be when they arrive. So there is a power of work yet to be done, notwithstanding this very exhaustive 2-year process. It gets us to the starting gate, if you know what I mean. When we're talking about early detection, we turn up with a new set of guidelines, with a new brief, and then off we go, because implementing to make a difference is going to be the key. But happily, we will have a clear, evidence-based, proactive set of guidelines which can be uniformly implemented across the country to deliver health equity and improved outcomes. And that's where we want to be.
Very well said. I'm cognizant this is a very far-reaching, wide-ranging conversation. In terms of wrapping this up, what message would you like people listening and watching to take home regarding these draft guidelines?
So I'd, from the technical perspective, the epidemiologist speaking here, I'd like just to remind everyone that we've been through a very rigorous process to get where we're at today. These are evidence-based guidelines, and that's really important. So that where we've found the best international evidence, we've applied it in the local context and said this is going to work. Where we found gaps in the evidence, we've got the best minds in Australia who know these subjects. We've got consumers' input, and we've come up with the most sensible, practical, and applicable set of statements that will improve prostate health into the future. And so I'm really happy with where we're at the moment. I know that we could do some things better, and I'd love the public consultation to tell us where they think those things are, so that we can get this absolutely right from now and into the future.
Peter, over to you. Your final remarks and messages for those listening.
I think this set of clear, concise guidelines, instructions for practice, for general practice practitioners and specialists, is based on an enormously strong and robust scientific base. And I don't think that can be emphasised enough. But hopefully, as we move forward, the implementation is key. Again, at the risk of repeating ourselves, health equity is so important. If we get this right and get a clear, organised program, we can really serve the men of Australia and their families.
And Jeff, last but certainly not least, your message for those tuning in.
Thank you, Katie. Look, to pick up very briefly on David's point, this is an evidence-based set of guidelines. I mean, for those interested, the background technical report itself is 300 pages. I mean, it is such a thorough job over this past 2 years, collecting evidence, analysing it, applying it through a specific process from, evidence to decision to grade. It's been an exhaustive process. So people out there can have confidence in what has gone on and how robust this scientific endeavour has been. As Peter's mentioned, it's getting us to the point where we can start to change practice, to change the way we go about detecting prostate cancer earlier, so we can improve outcomes, and about how it's important we get alignment from all the colleges and all the practitioners out there. In terms of a final comment, this is a significant step. It does take us closer to delivering on our shared vision, a world free from the burden of prostate cancer. That's together, collectively, that's our goal. This is a significant step. So we are getting closer. We have more technologies available for us. Our clinicians manage things in new and different ways. There's more research in the pipeline that will evolve and mature. It is a time, I think, to be optimistic about the early detection of this disease, notwithstanding the great amount of work yet to be done. If you're a person out there with prostate cancer, all I can say to you is you're not alone. You can always contact us at the PCFA for a whole range of resources and advice and support, and please do. And for the community out there, rest assured that we are really interested in your views so that we can bring the best possible set of clinical practice guidelines for the early detection of prostate cancer to bear on our community to reduce the burden of prostate cancer for each and every one of us.
Absolutely. Well, Australia is leading the way. This has been a wonderful conversation. Thank you to Jeff. Thank you to David. Thank you to Peter for being on the panel today and really bringing this, I guess, clarity around the development of these guidelines to light. As we have mentioned, if you are tuning in, watching, listening, you can have your say in the public consultation, which is open until the 25th of May. Again, that website is pcfa.org.au. There's a bunch of resources on the Prostate Cancer Foundation of Australia website. You can also check out prostate.org.au for more information and great toolkits and messaging about prostate cancer. But thank you again to all of our panelists. Wonderful the work that you've done. And thank you for watching. We hope to see you in the next PCFA webinar. Bye for now.